So welcome everybody in another case of the week. It's been a couple of weeks, but we have a really interesting case today.
So we have this interesting case of a 70-year-old male patient that presented to us with almost complete hemiparesis of the left side with aphasia, dysarthria resulting to almost 11 NHS points.
Okay, yeah, I mean, it's a really interesting case because you see the native CT. I don't think we can find any early signs. You can see some signs here on the right insula, but those are older infection. He had actually a known older insular infarct. You know, I think it's a really interesting case because it shows the potential and the value of CT perfusion. On the CTA, we could not actually find the occlusion. We can see the M1, but then we could not find really the superior trunk. So, you know, we were kind of sure that, you know, something is missing, but, you know, if we check here the thin slices, you will actually see that, you know, the M1 is okay. Then you have your bifurcation, your curve of the bifurcation there, but actually, you know, there is a vessel missing, which you don't see where the occlusion is. So, you know, I think this is a case where having perfusion, being able to see the deficit is really helping you. We can make a MIP out of this. If we really take a really thick MIP here, you can maybe try and say that, you know, this is your superior trunk. But obviously, if you scroll a little bit, you are sure that, you know, it's not, because this is the anterior temporal artery. Yeah, there is a big vessel missing there, but you know, it's a really great case because you cannot actually see it. And it was the same case actually on DSA, which is one of the really few cases I've seen it like this. So I call those the CCOs, Clean Cut Occlusions, right? So as you can see here, even if I make it this big, you don't really see like a occluded vessel there, right? It's a clean M1 finishing there. This one is an artifact from the orbital bone. So you can see this bony artifact, not a dissection. And then actually you cannot see the occlusion there, although we know there should be an occlusion there, right? Where do we know that? How do we know that? Well, again, we had CT perfusion, right? We can show you the CT perfusion right now, and then you see the big deficit. Of course, if you go to the angio, you can also kind of see those lateral images as perfusion images, and then you see that a big chunk of the MCA territory is missing there.
We know that this part of the parenchyma should be perfused by the vessels of the superior trunk, which we couldn't identify on the CTA, so we are searching for a superior trunk occlusion, right?
Exactly. We cannot even identify it on DSA. So our plan here was to go with the microwire and try to, you know, slowly find our way to the superior trunk. And as you can see, we're trying to find carefully this branch. Obviously, you cannot go, you know, with a lot of speed in there and a lot of push and power, because it could be a small lenticulostriate branch, right? As you can see on the lateral image, it has, you know, the contour and it has the curves of the superior trunk. So, you know, after going a little bit in there with a microwire, we were then sure that this is the superior trunk. And then, well, the question arises, you know, which technique are you going to use? In this case, we had just gotten the RED 43 in Europe. So my idea was to try to get the RED 43 in there. The catheter glides nicely in this vessel. And then as we have more inner diameter now compared to the 3-max, I decided to do just aspiration there, try to ingest the clot, and then remove it from this distal branch.
So if I understand that correctly, we see the shadow of the smaller catheter inside that superior trunk, as you said before, but we also see another bigger catheter. Can you explain us?
Yeah, we have described this before for the Quattro technique. When we are doing distal occlusions, we really like to have a big aspiration catheter in the M1 to be able to control clot fragments or 4 clot fragments when we retrieve the main clot. So as in this case, you can see the red 43 is there. We have now the M2 clot captured, but when we will retrieve this, the point stays that you have another catheter there. This was the red 72 to be able to control 4 clot fragments. So what we did is we had the Vaclox syringe connected to the smaller aspiration catheter, and after 2 minutes we retrieved into the big aspiration catheter where we had the pump aspiration. So you have continuous aspiration there, and you're able to retrieve safely the clot. You can see the result on the final angiogram, where you have a really nice reperfusion of this superior trunk. Actually, for the superior trunk is a Tiki 3, obviously, and then you can see the occlusion that was there before, also as we discussed in the M5 of the inferior trunk. We gave some TPA for this occlusion, but we decided against going with mechanical means so far into the brain at the moment. This is maybe something for the future, but I think until now we need to have evidence for M2 occlusions. We have this evidence now, and regarding the M5s, we will see in the future if we're going to do that with mechanical means. It didn't open with TPA.
That small parenchymal volume that is perfused from this vessel is very smaller compared to that perfusion deficit that we just saw a few minutes earlier on the initial perfusion imaging.
We have the comparison now on screen, so you can see the lateral images before thrombectomy and after thrombectomy, and you can see that you have more than two-thirds of the MCA territory that it's being reperfused now. And I think this is nicely also seen clinically, because the patient went from NHSS 11 into 0 in just a couple of hours after treatment. This is the final Dyna CT, where you can see that we don't have any bleeding, right? Even those small SAH that you sometimes see after thrombectomy of distal occlusions, there is none of it here. What we also want to see is the MRI after 1 day, right? Yeah, it also kind of explains the good clinical outcome with NHS of 0. So you can see that the majority of the MCA territory looks good. You have some smaller DWI lesions there on the territory of the superior trunk, but obviously this did not recanalize, so we have this bigger infarct there. But again, luckily for the patient, without any consequences. This is just one case. We're happy that it worked with aspiration only, but of course, first of all, we need the devices, and I'm really happy that we now have newer devices also available in Europe. And on the other side, we also need data from the trial. So we know that from the distal trial, we're going to get a lot of information regarding the different techniques. No, again, I'm happy that we now have available the devices. So.
Marius, thank you for explaining us the case so thoroughly. What would be the take-home messages for beginner and for more experienced neurointerventionists?
I think for everybody, every neuroradiologist, neurologist, neurosurgeon, it's important that perfusion has a place in distal thrombectomy, in distal diagnostics. If you want to find those occlusions, you need to use your perfusion imaging as a MeVO detector, as a DVO detector. So that would be my first point, and this is just a great case showing that. The next point would be, sometimes you have to adapt, right? You have to change your techniques, and it's great that we now have newer devices available, like the Red 43 to do that, also in Europe. But I think, as we see in this case, we should do this more and more in the future, right? This is a patient that went from NHSS 11 to 0 in a couple of hours.
To me, it was very interesting how, although we didn't have any signs of a stroke, of an acute stroke, in the native or in the CTA, that by using the perfusion going back, we had, and of course, with our anatomical knowledge, that we could not find the occlusion, but find where the occlusion and the occluded vessel should be, and then give that information to our neurointerventionalist colleague. And if you know where the occlusion should be or a vessel should be, then you can go very dedicatedly and search a bit. and the vessel would be there if you have the clinic and the perfusion deficit. Thank you so much.
Great, thank you.